have some staff that are like, why did they come to the hospital if they're going to decline? And I'm like, no, I love this because just because you enter through the doors of the hospital does not mean that you don't get to make choices.
Hello, and welcome back to another episode of the Birth Lounge podcast. All right, you guys, this week we are talking about one of my favorite subjects. And I think it may be kind of weird when I tell you what it is because you're probably going to be like, what the heck, HeHe? Why is this one of your favorite subjects? And let me tell you, it's because there is so much fear around this topic, but when you break it down, you find that A, it's actually super rare, and B, there's so much that you can do to stay in control of this situation, not only to avoid this thing, but to resolve it as well, and that is shoulder dystocia. Now, shoulder dystocia is an emergency. It's a rare obstetrical emergency where a baby's shoulder becomes lodged behind the mom's pelvic bone or her pubic bone right after the baby is delivered. So in these scenarios, your baby's head is on the outside of your body and their neck is in your vagina and their shoulders are having trouble rotating in order to exit your body. Now, in these moments, preparedness and innovative obstetric care are essential to ensure the safest outcomes. But what we know is we can actually do a lot before the birth of your baby to prevent a shoulder dystocia. Now, SD gets brought up a lot in terms of the so-called big babies, but what we do know is that big babies are no more likely to have shoulder dystocia than smaller babies. It does not matter the size of your baby. What actually matters more is how you labor and the position in which you birth. We know that birthing on your back is not great for you. It causes more tearing. It's harder, but it also results in more shoulder dystocia. And one thing that I find absolutely fascinating is that ACOG, and you can find this in Practice Bulletin 178, they actually have no level A recommendations, only level B and C, which does indicate that the data we have is limited and insufficient. So I just mentioned a few things that we could do to help avoid shoulder dystocia, but what if shoulder dystocia does happen? Well, the good news is we have a number of maneuvers to help resolve it. And one of my favorite is simply getting on hands and knees. Today's guest, I'm so stoked to have on the show. She is a certified nurse midwife and has been a labor and delivery nurse for 6 years. Worked in 3 different facilities, including high-risk units and low-risk units. And her practice philosophy is all about empowering patients to be informed about their care, normalizing physiological birth, and providing the midwifery model of care to high-risk patients. I mean, it's no surprise I'm having her on the show. You guys, I'm so excited to introduce you to Marisa Huebsch. I originally connected with her on Instagram, and you know how I do on Instagram. I will follow somebody, I'll check out their vibe, I want to kind of feel things out, and I have to be honest, Marisa instantly drew me into her. I knew from basically the day I started following her, I gotta have this lady on the podcast. She is just so good. The way that she speaks about autonomy, the way that she speaks about patient centered care, the way that she speaks about human rights in the female physiological birth process, oh, it just gives me the warm and fuzzy. She jazzes me up in the way that she genuinely cares for her patients. And so I reached out to her and I said, I want to have you on the show and I'd love to have you talk about something a little controversial, shoulder dystocia. Immediately she said, let's do it. So I'm so stoked for today's episode. It is going to empower you to not only understand what shoulder dystocia is, how often it happens, what we can do to prevent and avoid it, and how we can resolve it, plus all of the options that you have and the questions that you should be asking your provider in your pregnancy, in your prenatals, not at birth, but before your baby gets here, so that you can remain in control of this situation if you find yourself in this rare scenario where your baby is experiencing a shoulder dystocia. So without further ado, Marisa, welcome to the show.
Hi, thanks for having me.
I am so stoked to have you. You have no idea. First of all, I feel so drawn to you and the things that you post online and your philosophies and your just belief and trust around birth. But also the topic that we're talking about today, I really cannot wait to dive into shoulder dystocia. And I'll give you a little background. I obviously, for listeners, am not a medical provider. So I've never had the responsibility of managing a shoulder dystocia. And so when I first started my career as a doula, I did hold a lot of fear around shoulder dystocia because that's what I was taught. And for the first couple of years, I only saw them medically managed in the hospital system. And then I had the privilege, and I say a privilege because it totally changed my life, of seeing them managed in a couple of home births. And it literally changed my life because I went from being so scared of shoulder dystocias to understanding. Now, while they're serious, and I don't want anyone listening to feel like I'm dismissing or downplaying the seriousness of them, they are certainly an emergent complication, but they don't have to result in an emergency. And those are different. They can be a serious complication that arises that needs emergent attention. It needs immediate attention. It needs skilled attention, but it doesn't have to result in trauma and a so-called emergency for that family. And so I'm just so excited to dive into this because I think shoulder dystocia is one of those really looming topics in birth where you don't get a lot of information about it. It is really built up to be this terrible, scary, horrible emergency. We do know that it's unpredictable, so we don't really know who's going to experience one. And it is not preventable, so there's not really much that we can do to prevent it. But we'll talk about some things that we can do to mitigate the risk. But as far as who experiences a shoulder dystocia, that's the scariest part because we just don't know. But what I think I'd like everyone's takeaway from today's episode to be is that you have a lot of control in not only mitigating the risk, but how it is resolved. And also, it doesn't have to be this really scary thing. So, before we dive into all that, which I know everyone's ready for the meat and potatoes, let's start with you explaining what a shoulder dystocia is, and then maybe the different ways that we have to resolve them. And then we can dive deeper into what each of those are and where you might find those available and what providers are going to be qualified and which ones, things like that. But let's start with the very basics.
Yeah, I think you're absolutely on the right track as far as not every shoulder dystocia needs to end in this big, chaotic, traumatizing, all these people yelling and rushing into the room. And that is definitely something I tried to take away with me from my transition from a labor nurse to now a midwife provider within the hospital system. So there are several maneuvers that a provider will utilize to try to essentially rotate the baby. What a shoulder dystocia is, we talk in anatomical terms and planes. So you have anterior and posterior. And essentially what's happening is as the baby is making their cardinal movements through the birth canal and then the head delivers, that's not baby's final cardinal movement. They have to do something called restitution. Now, in a uncomplicated non-shoulder dystocia birth, as that's happening, the head delivers, the baby shoulders will rotate through, and you see them complete that like last J-shaped movement of expulsion as they come through the birth canal. And that's when mom or dad or anybody grabs baby and they come up on the belly. What happens in a shoulder dystocia is that anterior or posterior shoulder gets caught on some part of the bony inner part of the pelvis, whether it's the pubic bone, whether it's the sacrum. Now, if you look at like studies statistically, we're usually going to see that it's an anterior shoulder. That's typically what's going to be the most common cause is an anterior shoulder dystocia.
Oh, the top shoulder.
Yeah, top shoulder. When we think anterior, we're thinking front of mom. So facing towards their belly, posterior is facing towards their tailbone. So that knowing that is also what helps guide a provider into what are their go-to movements. Now, when you're trained as a labor nurse or as an OB or midwife, you are trained in there's a certain maneuvers, and you have your primary maneuvers, your secondary, and then your emergency maneuvers. Your primary maneuvers. Now, the unfortunate thing is most of the management is within the medical system when we think about who's creating these guidelines. So they're going to start with, hey, we're going to do McRoberts position. What McRoberts position is, it's all about tilting the pelvis. Now, this works really, really well for a patient who's epiduralized, who's already pushing in a supine position. Their legs are either up on foot pedals or up in stirrups. However, if somebody is non-epiduralized, this may not be the most ideal position to start with, and we'll get into that. McRoberts position essentially starts with it's not just pulling your legs back, we're actually trying to tilt the pelvis. So I always explain to patients, if this is something I'm recommending to them, I let them know, hey, I want you to relax your legs. We're going to try and tilt your pelvis, help your baby shoulder come out. The nurses are going to help you with your legs. So you can hold on to them, but I want you to let your hips relax because the goal is, I tell them, knees to your shoulders. We're trying to really tilt their pelvic bowl backwards versus just extending their hips back, if that makes sense.
Yeah.
It's not about pulling their legs back to behind their head, but you're really trying to get that pelvic tilt, because what happens in that pelvic tilt is it actually increases the surface area of the pelvis to help get a shoulder underneath the pubic bone. Now, just McRoberts position resolves about 42% of shoulder dystocias. I think that is why it's most providers' go-to move. But again, yes, that works really well if a patient's already in a position that makes McRoberts easily accessible. But if they are not pushing in a supine position, which is on their back in stirrups, then it's not necessarily my first go-to for a variety of reasons. After McRoberts, oh yeah.
So the question is, in addition to the legs being pulled back, aren't you having suprapubic pressure being pushed down as well? Isn't there someone on top of your belly almost pushing your baby through your pelvis?
Sometimes. Now, typically, how the most important thing from a provider standpoint when I notice a shoulder dystocia is I'm announcing it to the room. I say, hey, there is a shoulder dystocia. Nurses in a management, or even if you're in a community birth setting, whoever is your birth assist or your second midwife or your doula, anyone else, you are announcing that is happening. One that can help with whatever your emergency protocol is, starting a timer. There's not a specific set time that says this is a shoulder dystocia. There always used to be like, oh, if it's longer than a minute. But there's a lot of nuance to that, because if you have a baby's head that delivers at the end of a contraction and you're waiting for another contraction, that could be 1 to 3 minutes alone just waiting for delivery of the head. So the nuanced definition is you have a prolonged period time between head and body delivery, as well as you are requiring maneuvers to allow delivery of the rest of the baby. So when I announce the shoulder dystocia and I request McRoberts position, usually I'm also letting the patient know what's happening, because I know it's really scary. I say, hey, we have a shoulder dystocia. I need to help your baby's shoulder rotate out. It's really important for you to listen to my voice because I'm going to tell you when to push and when not to push. And that's your only homework. So I use that 10 to 15 seconds I have of lock eyes with me. I got you. This is scary, but we are going to do what we need to do. And when I do, that's also an announcement to the room of let's let all the background noise get down. No other staff should be talking in the room. Everybody should be listening to the patient and listening to the provider because we have our hands in there and we can feel what's going on. Suprapubic pressure comes in handy when it is a simple anterior shoulder and if you can tell which way the baby is facing. Typically you can once you get your hands in there. Obviously it's a really invasive exam, can be really uncomfortable even with an epidural. But what you're doing is you're trying to figure out which way is baby's shoulders this, the head's coming out, is baby's shoulder this way or are we this way? And the suprapubic, what you're trying to do is you're trying to flex the shoulders inward, decrease that surface area so baby can rotate out on their own. But that's not always going, that's not my go-to move always is suprapubic. So that's where, but some providers it is. So that's where it's just important to communicate like what you want the patient to do, what you want your ancillary staff to do. And again, maybe it's a posterior dystocia. And in that case, suprapubic will not help you because it will not, you just don't get the volume of flexion that you're going to need in your shoulders for them to rotate. And so a lot of what we do is determined by what are we feeling. That is really going to be the most important part. So if a patient, again, if they're in that standard position that we see in the movies, which is they're epiduralized, they're on their back, our hands go in, we're feeling where their shoulders are at. When they initially do McRoberts, we're actually going to have the patient stop pushing. What we don't want them to do is push that shoulder further into the pubic bone. So that's where I first tell them, hey, stop pushing. That also allows me more space to get my hands in there, feel, is this a simple, did baby just need a little like tilt one way or the other and they can come right out? I would say most dystocias are resolved within 60 seconds of initiating a maneuver. If that first maneuver doesn't work, you start with McRoberts, then you can add on suprapubic. And the goal of suprapubic, and I've had it be really successful. If I have a nurse who knows how to give really good suprapubic pressure, it's not only about the force, it's actually about where are they doing it and what direction are they pushing in. So you don't want somebody pushing on the pubic bone. It's suprapubic, which means it's right above the pubic bone. You're going to push, you're essentially what they're doing is pushing on the back of the shoulder and bringing it inward. And I've seen how when they have really effective suprapubic pressure, that baby completely finishes their restitution and they are delivered within that maneuver. And so that usually will resolve it. And then if it doesn't, there are some internal maneuvers. That's where me as the provider, I'm doing some things internally to help baby rotate versus the mom pushing or a bedside staff that's helping with suprapubic pressure. One other thing that I wanted to talk about too, as far as maneuver goes, is that every provider, again, they're going to have their preference. So depending on what position that patient's in, if I have a patient who's already, maybe they're in side lying or they're already pushing in hands and knees, or if they're in a squat position, and then we're noticing that there may be a dystocia, then McRoberts and suprapubic are not going to be my go-to. Usually, I actually took the Spinning Babies course resolving a shoulder dystocia when I was in school, and they talk a lot about getting mom in that hands and knees position. They use the flip-flop technique. And without getting too into the weeds, because I want to give her credit for her course, but essentially you're using gravity and you're using the anatomy of the mom's pelvis and them rotating themselves on their own. And when I've done that, again, a majority of the time, just them flipping into a hands and knees position will resolve it on its own. Or the patient can be a little bit more autonomous in how they're manipulating their own pelvis. So if they get on their hands and knees, they get into a runner's lunge position. A lot of times they can feel too. If they don't have an epidural, they can tell which shoulder is stuck or they can tell which leg they need to bring up. They do that and they kind of shift their hips a little bit, wiggle back and forth, and their baby will come right up onto their belly.
That's what I've noticed as a doula too, is that if we just get you in hands and knees, 9 times out of 10, that shoulder will resolve itself itself. And if that doesn't do it, get yourself in a runner's lunge. And also sometimes just like sitting up, if you're in a hands and knees, sometimes just some upright
Yeah.
position will help resolve that shoulder. And your baby just needs a little bit of a different angle to
Mhm.
be able to navigate the pelvis.
Exactly. That's one thing that I also think is important for patients to know is shoulder dystocias, though a risk factor is fetal macrosomia, it is not about size. Most shoulder dystocia, true shoulder dystocias, babies weigh less than 4 grams. So that doesn't even meet criteria for fetal macrosomia. So I think that that's important for people to understand, especially when, you get close to the end of your pregnancy and somebody either maybe it's medically indicated or maybe it's standard in your practice of getting a growth ultrasound in that third trimester or between 36 and 40 weeks, and you get told, oh, your baby's measuring really big, we don't want to risk a shoulder dystocia. As a patient, you may think, oh, I've heard of that, that sounds really scary, yeah, I don't want that, let's do an induction or let's do a C-section. And actually, even within ACOG guidelines, they do not recommend induction for fetal macrosomia. And there's so much gray area, as a midwife who practices in the hospital, shoulder dystocia is really, like you mentioned before, like you're taught that's the thing to be scared of. And it's true. You want to have a healthy level of fear to where you respond correctly and acutely in order to resolve it. However, I don't practice and I don't give recommendations based on fear. Just like I don't want my patients making decisions based on fear. I want it to be an educated decision. And the guidelines at this point say that if your baby is estimated under 4,500 grams and you are not diabetic, then there is no need for recommending an induction or recommending a C-section. And actually, when we think about litigation, because that's another thing that providers and nurses like to throw around, that actually can tie your hands. If you're claiming you're inducing someone for fetal macrosomia and then they have a shoulder dystocia that was not resolved quickly, you have now opened yourself up for litigation. So that's something for providers to keep in mind too. And induction in and of itself is a risk factor for shoulder dystocia. So when you're trying to tip the scales one way or the other, and I've had patients, maybe they've had a bigger baby in the past, or they've had a previous shoulder dystocia, and they want an induction. They know how baby's been measuring. They know how they feel in their body. This baby's getting big. I really want to try and avoid that. And I feel like my baby is term and healthy. That's them making an educated and informed decision of something that they are comfortable with, not necessarily somebody coercing them into a decision. So there's a big difference there too. It's not saying you can't induce if you think you're having a big baby. I just never want that to be the primary indicator for someone choosing an induction before 41 to 42 weeks.
Because we know an induction doesn't prevent it. So it's almost like a lie. It's let's do this so that we can prevent steroidal dystocias. That's a lie. We'll never be able to prevent it. Not even with an induction. The only way to prevent it is a C-section. And that should be reserved for babies that are super big, actually meet
Yeah.
macrosomia and
Yeah.
that parent agrees to it. So it
Mhm.
doesn't mean that if you have a super large baby over, what is it, 4,500,
Yeah.
5,000
So if you're
grams.
non-diabetic, baby over 5,000 grams. If you are diabetic, whether it's gestational type 1 or type 2, any type of
Sure.
diabetes diagnosis, then it's 4,500 grams,
Okay,
which
so
that's a very large baby. And when you
oh,
think
that's a
about
huge
that,
baby.
most of them, I know, when most of the dystocias are less than 4,000 grams, you're like, well, where is the center of that Venn diagram? Like the math just doesn't math in reality when we're convincing patients into inductions for things that we're not actually protecting them from.
Okay, so where do you think the overlap is? Where do you think that discrepancy is? In my opinion, I think it's Pitocin use and having people push on their backs and not using upright pushing positions. Would you agree with that?
I think there's a lot of factors, and I think those are some of the biggest ones. Pitocin, and the way so in my practice, I am in a very large practice where the midwives are managing labor. We have physicians on the floor there for emergencies, but unless a patient requests a physician, it is a midwife who delivers them. I'm really lucky to where I moved my family across the country to choose this type
Oh,
of practice.
wow.
And we always have two midwives on staff. And so as a new grad midwife last year, I always knew I had someone to run things by. In this large practice, we are about in line with the national standard as far as about 30% of our patients are delivered by induction, which is something we've talked a lot about as midwives. We are not the ones counseling them into inductions. Obviously, there's medically medically indicated, and then there's elective inductions. We don't schedule elective inductions. They go on a wait list. And sometimes we'll go through a month where we're like, wow, no one's gotten on their elective induction because they've all come in labor, which is what we prefer. But when we look at the data over an entire year, we're like, okay, we're still within that national average. And I am always thinking, like, how can I bring that percentage down?
Totally.
Because even though most of our patients still deliver vaginally, I think induction in and of it, there's, like you said, there's so many variables with it. When somebody chooses an induction, it is a non-physiologic process. And I think we forget oftentimes that all of the things we're using, all of these methods, they're tools in the toolbox. We don't need to utilize all of them. We don't need to utilize any of them. It's always, we can pick and choose based off of a patient's medical history, any relative contraindications, but also what the patient wants to do. Now, I utilize a lot of cervical ripening balloons. It's one of my favorite things. With informed consent, I also offer to pre-medicate my patients. I've never had one placed. I've seen them placed and they look very uncomfortable. So I will always offer to pre-medicate them. And I've had patients come in and have a really long induction because they declined a cervical ripening balloon. And in the back of my head, I'm like, okay, I think this would go faster. But I try to never let that show on my face because at the end of the day, that's their choice. And I think patients forget that too. If they're choosing an induction, they don't have to go with what the standard induction methods are. Even if that is maybe not what I would recommend. Again, it's 100% their choice. And I also don't want them choosing something because they think that's what I want to hear. I want a patient to know at the end of the day, especially when a patient ends up having a shoulder dystocia, or maybe they end up in an unexpected C-section, I want them to know that happened with them doing everything they could in their power and me doing everything I could in my power to give them the birth that they wanted. And so most of my patients, I personally have a very, very low C-section rate. I could probably count on maybe two hands how many patients have had an unexpected C-section when I'm on call in the last year. And that is because, and most of those I actually would say were parental choice.
Mm.
Patients didn't actually meet criteria for failure to progress. Usually about at some point, they're like, actually, I'm done. Yes, I know you're doing what you can to help resuscitate my baby in utero, but I think I have this feeling and I think this is what we want to do. And I say, okay, I support that. Let me go over the risks and benefits with you. And same thing goes for shoulder dystocia and induction. They have to know what their options are. They have to know what choices they can make. And because I want them to walk away without any regrets, because there are a lot of unpredictable things about birth. There's so much out of my control and out of the patient's control. But I want them to know that the things they can control, they did what they wanted and they did what felt good to them, because then I think that's where the trauma happens. I think it happens when they feel like choices are made for them instead of them making those choices. And so when those choices are made for them and they end up with the epidural they didn't want, and they end up in the birthing position they didn't want, and they end up with the episiotomy they didn't want, or the vacuum or forceps, all of those things because they're phrased to them as we need to do this. This is an emergency when maybe it really wasn't an emergency.
Mm.
And that's a really important conversation to have with them. I tell all my patients, even in an emergency, I have 15 seconds to ask for consent. I've had a cord prolapse and I tell them, this is a cord prolapse. This is an emergency. Your baby cannot be born vaginally, but you have to give me the okay. I need you to understand a lot of people are going to come in the room. It's going to feel really scary, but I'm right here. This is what I'm doing with my hand inside of you. This is the physician who's going to come in. I need you to know what's happening and tell me that it's okay. And obviously, I've never had a patient tell me no, and that's when we have those. But just, I think of, can I imagine not really knowing what I know? I've grown up in the birth world, but if I didn't know what I know, and someone just told me your baby has to be born via surgery and you don't have an option and you don't understand what's happening to necessitate that, how traumatizing that would be. So that's really how I try to phrase those conversations with patients so that even when emergencies happen, they have choices.
Yeah. Oh my gosh. I try and phrase my presentation the same way with clients is just if I didn't have the knowledge that I had, what would I want to hear? How would I find a place of peace and comfort and safety in what someone was telling me? And what would I want to be told in this situation? How would I want to be supported? And with our one-to-one clients, we spend significant amount of time. Most of our one-to-one clients are usually working with us by about 12, 16 weeks pregnant. And so we have months to be able to learn who they are and how they receive information and how they like to be talked to and spoken to and supported. And it makes it so much easier to navigate traumatic, emergent situations, unexpected, even if they're not emergent or traumatic, they're just unexpected, which is almost inevitable. Every birth is going to have moments where you go, wow, I did not see that one coming. Some positive, some negative, but there's always moments where you go, wow, that one, that caught me off guard. I did not think that was going to show up here. Okay, I have a question about providers who immediately call shoulder dystocia. How do we, as patients,
Mhm.
and this is tough because let's say that we are on our back,
Mhm.
even though you and I know that's not the best position. And I think a lot of people don't want that. But I want to talk to the masses. So I want to talk to the people that I want to talk to the majority of how we're going to end up. And even though a lot of us don't want to end up on our back, we're still in this learning curve where many of us get put on our backs regardless of what we want. And we haven't quite made it to the place where we are truly really good at advocating for ourselves. We're getting there, we're getting better. It's a learning curve, but I would think that a lot of people do look back on their birth and say, gosh, I wish I had not been in that position. I didn't really want that. So let's say we're on our backs. Our baby's head is out. I've been in so many births where literally the head pops out and a doctor goes, shoulder. And
Mhm.
you're like, how do you even know? You haven't even
Mhm.
waited to see if restitution is going to happen. So,
Mhm.
two questions. A, what do we do in that situation as the consumer, as the mom, as the birthing person? How do we know? And maybe there's not a way. Maybe it really comes down to finding a provider that you absolutely trust 100%. But how do you know that it's a true shoulder versus they just did not give your body enough time to honor restitution? And
Mhm.
then B, if you do realize, wait a minute, I think you just didn't honor restitution. What
Mhm.
kind of control do we have as patients? Do we just say, no, thank you, I'm willing to wait? Or is this the place where we go, you know what? Great, I'm going to get on hands and knees.
Yeah, that is a really tough question because when you are the birthing person on the bed, you can't reach your hands inside and feel where, and even if you could, would you know what you're feeling for? Because as a
Right,
new midwife, I was like, I don't know what I'm feeling. I hold babies
right.
on the outside, not on the inside. So I think one, trust in your provider is paramount. I think also having that conversation ahead of time of asking them, what is your standard with delivery? Now, rarely I can notice a dystocia right away. And
Okay.
some, but usually there are signs before actually the head's even delivered. One, if we're crowning for an abnormally long time, sometimes it's because head's trying to deliver and the shoulder's like getting stuck on here. Or if you get to a large crown and then all of a sudden in between, baby moving backwards a little bit, pretty common. But if you deliver to a large crown and then baby all of a sudden kind of sneaks back in
Oh,
between, and then you're only seeing this much of the head, doesn't mean it's going to be a shoulder dystocia, but it is something that I'm like, okay, my spidey senses are going off. That's where I'm asking my nurse, hey, do you want to break my bed down for me? Because I don't normally break my bed down. Or I'll make sure that I have extra gel at the bedside. And some of the nurses I work with more often, they'll know. And again, it's like we're setting things up like superstitiously. Let's throw away the bad juju, get it out of the room, get things set up because I don't want to cause an unnecessary panic. I don't want to call a shoulder dystocia, have a million people come in the room and then baby comes out. And then this patient's birth was like totally disturbed unnecessarily. Another sign sometimes is as the head delivers, baby can have what's called the turtle sign, which is the same thing. They'll come out and the head will deliver and it totally retracts and you'll see the baby kind of turtle back in. That's a similar thing to like their shoulder, one way or the other, is getting caught on a bony part of the pelvis. But I would say those don't happen often enough to how many times I saw too as a nurse. So we used to joke around. I think that was maybe just a resident dystocia when we had
Totally.
like newer doctors. But it was just a learning curve. And when as a provider, because you're always on guard, you may call it soon. I've probably had a dystocia that I've called too soon.
Mm.
I typically try to do a two-step delivery, but in being in like in the fully like we're always learning and always trying to be better, I'm sure that there's been a couple dystocias that maybe if I would have waited another 10 seconds, maybe baby would have turned on their own. I don't know. And that's always a conversation that I have with patients. I think that's important in debriefing with them afterwards. So, as a patient, your baby's head's delivered, your provider calls out shoulder dystocia, and your spidey senses as a patient are going off saying, I'm not quite sure that's actually what's happening. Can we be more patient? I would think I would ask for, hey, before you do a maneuver, can you tell me what shoulder is stuck? I think that could be helpful. And maybe the provider has, if we're thinking the worst of people, maybe they already have some saying that they tell patients to make them do what they want. I try to believe the best in people, even though, and so I think you just have to have trust in your provider. It is hard because time is not on our side. In a shoulder dystocia, the longer, even though baby's getting blood and oxygen through their umbilical cord, just that constriction around their neck is not great for them. And the longer that they are inside, then usually the little bit more resuscitative support they're going to need on the outside. I think some of it could be more retrospective, debriefing with your provider afterwards while they're waiting on placenta or while somebody's maybe helping work on your baby if they did need some help, asking them, hey, can you describe to me what maneuvers you did that worked? What did you feel? One, if you keep that provider for your next baby, then like they're going to be familiar with what happened. But two, if you move or you choose you want a different provider, that's really helpful information for your next provider to know. Because if I had a patient that tells me they had a shoulder dystocia, and I'll usually ask them, do you remember how long it lasted? Do you remember what things they had to do to you to get the baby out? And if I have a patient that says, I don't really remember, it was super blurry, I like a nurse pushed on my belly and a baby came out and baby went to the warmer but came back to me within a few minutes. That's a lot different than when I have a patient that tells me, yeah, I remember it lasted a few minutes. Baby went to NICU. They had to be cooled. Like those are two very different outcomes. And that's really helpful for me to know as a provider because one, I'm going to have some tools in place at the bedside so we don't run into that several minute long dystocia as much as we possibly can. I'm going to have a resuscitative team like on standby because I want that patient to know, again, you do what you can control, I do what I can control, and then the baby and your pelvis determine the rest. In that moment, it's a very vulnerable spot to be in because you don't have a lot of control. But I think debriefing with your provider afterwards at least arms you with the information moving forward. Even if it didn't prevent what happened to you, it's going to help you process what happened, help you understand the parts of your birth story so that moving forward, you're not looking back years later and you're like, was my baby really stuck? I'm not really sure. If you can get a good little debrief and write those notes down in your phone or in a journal, if nothing else, just for yourself to go back and process. And I do that often. Again, like I said, usually while I'm waiting on placenta to deliver, I'll go over, hey, this is what I felt. This is what I had to do. This is what helped your baby come out. And I've had patients come back and tell me how helpful that was to them to understand what was going on and take the unknown scary parts out of it for them.
Totally. And three other places you can do that. So there's a lot going on right after birth. So it's probably helpful to hear that. But you can also do that during your postpartum stay. Anybody can explain that to you. You can ask for that doctor or that midwife to come back. You can do it over your MyChart or whatever online portal. You can have emails with your provider. You can request your medical records and have them debrief that. You can also do it with your follow-up, your postpartum follow-up, whether that be 2, 4, 6, 8 weeks later. You can ask them there. So you've got multiple chances. And if you have it at 1 or 2 and you need even more, take all those opportunities to learn what happened to you and your baby. Okay, Marisa, you talked about an abnormally long crowning time. What constitutes abnormally long?
Yeah, that's a great question because I've had some first time patients who I will let them crown if baby is doing great. Like I have
On the
no heart rate
monitors.
concern. Yeah, baby's doing great on the monitor. I have no heart rate concerns. I am a provider. I don't do a ton of perineal massage. There's a lot of conflicting evidence on it. I do warm compresses if the patient wants that. Sometimes I'll offer some like little bits of lubrication if the patient wants it. But again, I've had patients crown for an hour and 20 minutes, like
Totally.
because I have seen the more we're messing with the tissue, you're inflaming the tissue. And again, I want to know what is the pelvis and the baby and the contractions doing on its own without me doing anything. So I want to know how much are we crowning to? And I do think when a baby is crowning longer than 20 to 30 minutes for a first time mom, if that's happening, I have this belief that the baby and the pelvis are smart and the uterus is doing what it's doing. And maybe they're crowning for a long time to prevent a shoulder dystocia. Maybe the baby's navigating something. And so that's where I try to be proactive in the I have my outside tools ready, but I'm not going to do anything to disturb that quite yet. I just had an experience with a midwife student that was in the room with me for a dystocia and I'm in her ear talking her through everything. And even though I did have to intervene, when me and the midwife student debriefed afterwards, she was like, wait, what made you do this versus this? And that's what I was like, the less we do anything up until head delivery, the less I do, the better. I really don't want to be massaging aggressively. I don't want to be like pushing on muscles aggressively. It's really, if a patient's pushing effectively, I'm as hands off as I can be. And then same thing, once the head comes out and you're going to notice as a patient, you may notice your staff may respond to this differently. I think as I've gotten comfortable with my staff and they've gotten comfortable with me and we've built this trust with each other because I've announced to the room, okay, the baby's head's delivered, but your contraction is done. So I want you to take a big deep breath in. You're sending all the love to your baby. You're thinking stretchy thoughts, and we're just going to wait for another contraction. And everyone, you can tell, maybe everyone's tensing up, and we always joke around, everyone's buttholes are puckering because that's what you do on labor and delivery when scary things happen. But then it just takes that fear and it normalizes. I get in my like really nice customer service voice of everything's going great, and we're just going to wait for your baby to figure out your pelvis. And 9 times out of 10, they do. And when they don't, then my hands are there and they are ready to intervene as soon as they need to. But the two-step delivery is another thing that, like, ask your provider, what do they think about a two-step delivery? If that's something you can request. I talk to my patients. Usually I have a little spiel I give them when we start pushing as a first-time patient, because you know that it's probably going to take a little bit longer, especially if they're epiduralized. And so I say, hey, this is what like normal pushing can look like. For my goal is that you feel enough that you're pushing because you have that urge to push, not because I'm telling you you're having a contraction. And when I really want you to have as much control over this process as possible. And when your baby's head delivers, ideally, I want it to deliver at the beginning of a contraction. But if it doesn't, then we're going to wait for the next contraction. And these are the reasons why. And I list them out for that reason. And I tell them if baby comes out and I'm noticing signs that they need a little bit extra help because of their shoulders, I'm going to let you know. I just need you to listen to my voice. And that's just our kind of pre-brief, if you will, of what to expect when baby is delivering. And that I think takes a little bit of the scariness out of it for the patient as well. If I can tell them what to expect, and then once we get to crowning, I reiterate, hey, we're going to wait until the next contraction. And their baby may be hanging out with this much of the head out. And I'm going to do what I can to wait until the next contraction so that baby has the time and the power to rotate. And if they don't, then we intervene as necessary.
Yeah. Oh my gosh, I love it. I just keep hearing the overall arching message of don't intervene unless it's absolutely necessary. Don't preemptively intervene, especially because of your own fear. So there's a large part of this that is providers
Yeah.
dealing with yourself.
Yeah.
that self introspection, that self reflection. Go into therapy to
Mhm.
work through your own fears and biases, your own past traumas, because whatever you're not working through, you are bringing into that room and you're putting it on the patient. You may think you're not, but you
Mhm.
are. And I think that is really missed in the healthcare system, just totally overall in every single unit, floor, department. I think that's just overall. And I don't think it's providers' fault. I think the healthcare system has taught you guys and conditioned you to just suppress and repress
Mhm.
and bury. Don't let this stuff come up. Don't let this stuff overflow. Don't bring this into work. And at the end of the day, it sucks because you pay the price, but
Mhm.
your patients are also paying the price for
Mhm.
that. So if you're a healthcare provider listening out there, please, please, please do the work. Get into some therapy, do some meditation, do that mindset work. Go ahead and confront your biases and your fears. I promise you, on the other side of it, not only will you feel more confident, but you won't have to deal with that shitty feeling of being scared every time you step into a birth room because you will know that you know what to do and you'll feel confident and like, all right, not only do I know what to do, but I'm confident that I'll be able to handle this. And I'm surrounded by people that I also trust, and encourage the people on your unit to do the work, to face their fears, to confront their biases, to go to therapy, to work through their past traumas. It will not only make you a better provider, but it will give you better outcomes for your people.
100%. I think, especially in the birth world, even if the hospitals and the health system don't want to acknowledge it, I think we're doing better as individuals, as nurses, as midwives, as doctors of acknowledging that we are privy to a lot of secondary trauma. I think the key is of what are you going to do with that? Like you said, what are you going to do with that information? You may know that like you may experience a shoulder dystocia or a uterine rupture or a cord prolapse, and you think about, is this going to change the way I practice for the better or for the worse? I've been a part of some really, really tragic and scary situations and outcomes. I've had a patient have a uterine rupture, but I'm not going to be the person that tells someone they can't have a VBAC because of that. Like, it's scary, 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 and super awful. But again, if I used that one super rare incidence to dictate how I counsel hundreds to thousands of patients, that's not fair to anybody. It's not fair to me. That's a lot of expectations to put on myself. It's not fair to my patients because it means that they are suffering consequences of not getting true informed consent based off of my own biases. And that's not fair.
And they're suffering the consequences of a birth that has nothing to do with them, of a stranger that they don't even know, of a pregnancy that is
Yeah.
totally different
Could
than
be in
their
another
own
state, in
pregnancy.
another hospital, have nothing to do
Totally.
with them. Mm-hmm.
Totally. I always view providers as the end, the bookend on those tragic cases. And it's just the responsibility that you have of being a provider. It sucks, but if you are a good provider and you'll do the inner work and you'll work on yourself, it can end with you right there and you can leave it there. And then the next person who wants a VBAC, yes, you are letting that inform you. You're not ever forgetting that experience, but you are not letting it influence the counsel that you're giving that new patient or influence the decisions you're making. And so those are different. I think people often conflate being informed by a past experience versus letting it influence their practice. And those two must remain separate because they are very different and they will absolutely impact patient outcomes very, very
For
differently.
sure. It's like obstetrical generational trauma. Oh, that's essentially
Totally.
what we're doing. And if I let an experience when I was a baby labor nurse 7, 8 years ago influence how I provide care now as a provider, like you, yeah, it just, when those two cases are totally unrelated, and it sets them up for failure, and failure that patient's going to put on themselves, that has nothing to do with them.
Yeah.
And same thing, if we have a shoulder dystocia and then we use that incidence to, now we counsel these patients for 39-week inductions or for C-sections based off of inaccurate macrosomia estimations, then that is setting them up for feeling like their body wasn't capable of something. Versus if somebody has an unnecessary medically indicated C-section, again, they know that they did what they could, and I know I did what I could, and that processes in somebody's brain so much differently than if I'm making the decision for them, telling them, no, I need to induce you at 39 weeks. Your baby's measuring really big. I'm not, and that's where it comes from, right? The provider saying, I'm not comfortable with this. And even though we're just a part of the equation, we're a big part of the equation, but we're not the person going through it, and it's not our birth story.
And you, at the end of the day, don't have to really live with those results. You have that memory, and that was an experience that you lived through, but you don't have to wake up every day with that episiotomy cut. You don't have to go through 5 years of therapy because of what happened to you in your birth. You don't have to bury your child when there's a bad outcome. You get to leave that at the office and go home to your family and come back the next day at 7 a.m. and do it all over again, almost as if yesterday didn't happen. And those are really different. Those are really
Yeah.
different
Yeah,
experiences.
it's a very sobering thought, especially in the practice I work in. Though I do office visits, I am primarily hospital, like in the hospital. And so there's often times, I'd say a majority of the patients I deliver, I've never met before. I haven't, even
Wow.
though they may go in my see my practice, maybe they went to a different office location, saw a different midwife. I'm not the midwife who did any of their prenatal care. And so I see it as a really big responsibility on my part of I need to let this patient know that they can trust me and they can feel safe with me in a very short amount of time. And it's all about those conversations that are happening the minute I walk in the door. It's sitting down and talking with them and asking them, what can I do to help you feel safe? What things are really important for you for this birth? What are some fears that you're having? Let's release them out into the universe. And if we that just sets the tone for how that process is going to go for us. And I think that's really important. And what it's shown me, because I love setting those relationships up with patients, and I don't get to do that as much as I wish I could. But it's what it's shown me is I have patients come back, and the best thing you can ever do for a birth worker is just give them a card. We don't
Yep.
want all the fancy gifts, but cards with baby pictures are like my favorite thing. And I get cards all the time for these super, super special births of patients I didn't even meet beforehand. So it doesn't mean that you can't have a special relationship with a person who attended your birth. But to do that, it requires work on my part as the provider. The onus is on me to build that trust. It's not on the patient. I don't want them to come in feeling like they have to fight every single thing that I'm coming in to tell them. And even if I like really disagree with their choices, if they come in and their water's been broken for 4 days and they want zero augmentation, I'm going to say, hey, this is the evidence I'm going off of. These are the guidelines. But I'm like, usually if I can tell that those guidelines are making them uncomfortable, I'm like, listen, my job is to give you the information. Your job is to feel good about the decisions you make. And at the end of the day, I will hold your hand and I will support you, even if it's not the decision I would make. But that's not on you. I tell them all the time, like, how I feel, my discomfort is not your responsibility at all. Your responsibility is to walk away from this understanding the choices that you made.
Okay, you did it. You made me cry. I just wish that every woman had this type of care. I think that it would be so pivotal in our healthcare system. And I think it's something that a lot of us are preaching, but it's also something that is so unattainable for so many women with the access that they have or the lack thereof. It's what is available to you is not a Marisa. Not everybody has a Marisa. I hear it every day online. Not everybody has a HeHe. I wish I had a HeHe. I wish everybody had a Marisa, and it sucks to know that this is not the care that people are getting, because if this was the care people were getting, we would see birth trauma rates go down to almost obsolete. Now, there is some birth trauma that's unavoidable, right? Like it's going to be traumatic if you have a shoulder dystocia, but it doesn't have to be as traumatic if it is handled calmly and respectfully and your consent is gotten. And they say, look, you're on your back, you're unmedicated, you can flip over to your hands and knees, or we can pull your knees back. Which one would you rather? That right there mitigates so much trauma for so many people, and it's just not an option that a lot of people get.
And what some people don't realize is if in that scenario, not every unmedicated patient is going to choose to flip over. I think we because I fight so much for like patient autonomy as well. And I see when people are posting birth videos and I'll see comments of like, why is she on her back? I'm like, I'm not going to lie to you. I have a lot of unmedicated patients who want to push on their back.
They
They feel
choose
like
it.
they can pull their legs
Totally.
out. And so I think again, and say when you're at that point, you may have a patient that's, I don't think I have the strength to get on my hands and knees, can we try this first? And I'll be like, oh yeah, but if this doesn't work, we're going to have to give you the strength to get on your hands and knees. And most patients, when they know that it's an emergency, they're going to get the willpower that they need to do. But it doesn't always mean that patients are going to choose the harder option. And I think we need to remember that too as the provider. I'm not the person who has to flip on their hands and knees. The patient is. And if they are telling me, trust them. If they are telling me that they have the strength to do that with a baby's head sticking out of their pelvis, then I'm going to believe them and let them do it. And then there, again, that's a lot less work on my part because anatomically and physiologically, their body's probably going to take care of that dystocia all on its own without me needing to do anything except for have my hands there ready to catch. I'm probably not going to have to do much of anything. But when we force patients into these positions where the autonomy is stripped from them, the choices are stripped from them, like we actually are making our jobs so much harder, as well as stripping patients of like beliefs that they have about themselves. And I think that's what's important. I work in a hospital setting because that's where I feel called. I've heard you say similar things as far as like why you guys support so much like you have so many patients within the hospital and you're like because that's where the work needs to be done.
Yeah.
And I feel the same way. I had my first baby with an amazing midwife in a hospital setting. It basically was a home birth within a hospital and it was fantastic. I required some augmentation, but I chose what my augmentation method was. I chose when I started that augmentation and I did so knowing the risks, the benefits, and I had all the support behind me. If it was up to my midwife, I probably would have started it when I was admitted, but I didn't and she didn't let me feel bad about my decision. I'm like, I'm going to sleep and walk around and see how things go through the night. And let's check in the morning. And then when I decided, hey, I want to get this show on the road because I don't want an epidural and I know I'm going to get tired. So let's speed some things up. And then labor got hard. I wasn't blaming my midwife. I knew, hey, I made the choice. I made the choice to get through this. And this is the path that I chose. And as hard as labor was, like it was done and it was beautiful and empowering. And same thing, I wish everyone had the opportunity to have that experience within a hospital birth because we all deserve that, whether you want an epidural, whether you don't want an epidural, whether you want to deliver in your shower or over the toilet. I've had some toilet deliveries in the hospital that though, same thing, everyone comes rushing in and I have to remind them, the baby's out. This isn't an emergency. This is exactly what they came to the hospital to do. We're just going to have a calm walk over to the bed and you just have to remind people around you. But it starts with people like us, I think, that understand where we draw the line between pathology and physiology and to help people guide their choices, to give them information, that education, and then you just got to spread it around.
Me too. I wish that's what everybody got in labor. I'm very hopeful. I know I stand quite alone in that thought. There's a lot of people who just are not hopeful that the healthcare system will be fixed, but I am hopeful because, and I'm not talking about the whole healthcare system. I can't take that on.
Yeah.
That cannot be on my shoulders. What I am hopeful of though is that women are waking up and they are going to start demanding better. And eventually, the abusive providers will be pushed out because women are going to stop accepting that type of care. And the good providers like you and the voices that are fighting for these justices are going to be elevated. And so that's what I'm really hopeful for. I am so hopeful and I just can see it. I just can so picture what women's health can be like in America. I don't know how long it'll take us to get there, but I definitely think that we can totally get there.
Agree. And I think the biggest thing is to, because when you are a provider, I am the midwife I am because I was inspired by midwives who practice the same way. And when you do those things and you do good and you exercise patient autonomy and shared decision making, you inspire people to practice like you. When you have the provider who's the Debbie Downer that says how things are going to go and patients don't have choices, everybody knows who that person is, and they're all going to practice in spite of how they are. Nobody chooses to become like them. And so I think the same way. It's kind of natural selection. I think we're in a spot of the birth world and in obstetrical care that if we, like you said, we elevate those voices, they're going to continue to inspire other providers to not only be the same way, but it's going to inspire patients to demand that care and to demand better for themselves. And I secretly get really giddy when I have a home birth transfer and the patient's transferring for whatever reason and it's not an emergency and they're still like maybe declining certain interventions. And I have some staff that are like, why'd they come to the hospital if they're going to decline? And I'm like, no, I love this because just because you enter through the doors of the hospital does not mean that you don't get to make choices. I remind people, I'm like, this patient was out doing their laundry, buying groceries, paying a mortgage. And the moment they walk in does not mean that like we treat them like children. We infantilize these patients, acting like they don't know what's best for them. Like they didn't just spend 9 months or longer preparing for this very moment. And we have to remember that a patient can choose to come to the hospital and decline an epidural or decline Pitocin or decline to lay on their back or decline an IV. It happens all the time, and you can still have a very non-traumatic, non-emergency birth and decline certain things that you are like, that doesn't serve me and it doesn't serve the goal that I have for the birth and experience that I want to have. And birth plans do not sign you up for a C-section. Just all of the myths that we heard as far as at least that I did as a labor nurse who started out. So like, why are we choosing to hold on to these negative thoughts? Like, why not choose to hold on to no, when you're educated, it gives you power and that knowledge is going to allow you to have a better birth. Like, why can't we hold on to that?
And when patients decline things and you, as the provider or the nurse, don't agree with them, it's not your job to influence them or persuade them or coerce them. It's your job to give them the information, let them know why you're making the recommendation that you're making and why you think it's the best choice. But then ultimately, two things, putting it back into their hands and say, you get to choose whatever you want. And then whatever they choose, you honor that
Mhm,
without any sort of influence.
mhm,
No rolling of the eyes, no huffing and puffing, no demeaning language, no fear-based tactics.
mhm,
Just honor what these
mhm.
people want. It's
Yeah,
just,
exactly.
it is actually quite easy, but it goes back to what we talked about previously. If you have not dealt with your own fears and your own biases and your past trauma, you're not going to have the emotional intelligence to be able to say, I see this person, I respect them, and I'm able to honor what they are choosing.
No, 100%. I think too, I remember a situation where a patient was declining an intervention and they were kind of a long-term patient in antepartum and several nurses and providers were talking about, oh, I'll go talk to them about it. I'll go talk to them. And I was like, so the patient said no 3 times. I think if we go in there again, this is considered harassment. At that,
Totally.
because that's what it is. In
Totally.
any other scenario, if you were out on the street and somebody's knocking on your door and you say no, like you would call the cops and tell them that you're being harassed. So why are we normalizing this harassment within the medical system because we think we know better when we don't always in reality. We know what we've been told, but there's a lot of myths in the birth world that have been told. I see it all the time where we'll be doing something and maybe a new nurse asks like, "Hey, what's the rationale behind this?" And nobody can even tell them what the rationale is, or they come up with something that's not even accurate. And so I'm like, and those things are being perpetuated throughout the country because I've worked in multiple hospitals in different regions and you hear the same things. I'm like, that's all false. That's not even accurate. That's not why we're doing this intervention. That has nothing to do with it.
Wow, that is so unfortunate. You can just see how it is passed down from generation to
Mhm.
generation. And again, the patients are paying the price. Okay, something that we talk about a lot in this community is risk and benefits. I think that it's pretty clear shoulder dystocia doesn't have any benefits, so we can check that off. But
Yeah.
we don't not skip it. We're
Yeah.
just admitting there's no benefits to shoulder dystocia. However, we haven't talked about the risk, and I think that's a really important conversation if people are going to know how to navigate shoulder dystocia. So, can we talk about some of the risks for both maternal side and fetal side?
Yeah. So for maternal side, the biggest thing is pelvic floor injury,
Okay.
depending on if it is a size issue. Obviously, we talked about how size is not the number one factor, but if you are pushing out an 11-pound baby, your chances increase of a shoulder dystocia just for anatomy purposes. So pelvic floor injury, not only from the baby, but then also from the maneuvers the provider's having to do to help deliver your baby. Also, if they determine an episiotomy is helpful, so an episiotomy is not done to release a shoulder dystocia. It is only done if someone's perineum and vagina is not enough space for your hands to get in there. So it is
Wow.
not done to release the shoulder. It is done to increase exposure and accessibility to the baby. And obviously, if you have an episiotomy, then that increases your chance of a third or fourth degree tear, anal sphincter injuries, those types of things. And then there is also actually an increased risk of postpartum hemorrhage. I think it's kind of a multifaceted reason. I don't know that it's directly, oh, you had a shoulder dystocia, so you have a hemorrhage. I think, again, we look into, was it a bigger baby? Was that the reason why? Your shoulder dystocia, was it involved? Did you end up having an operative delivery? So
Mhm.
vacuum or forceps? Provider's hands are in there. Does all of that manipulation maybe change how your uterus responds to the delivery and how your placenta delivers? And so I think it's a little bit indirect, but that is a risk as well for postpartum hemorrhage for mom. And then when we look at baby side, the biggest thing is obviously any kind of hypoxic injury. If baby is going an extended amount of time without getting the needed amount of oxygen, but also brachial plexus injuries. So there's a branch of nerves right here. And so if a provider is either doing too much. Now, some gentle downward traction can sometimes is necessary. Sometimes it's not a shoulder dystocia. Baby just needs a little bit, they need a guide, they need a little bit more guidance out from that pubic bone. But if you are just yanking on their head and their shoulders doing this, and you can really damage, you can end up with certain types of palsy type injuries and things like that. So that's why one of the first things we do after a baby does have a shoulder dystocia is we are assessing their muscle tone in the arm that was affected. Or if we ended up needing to, one of my go-to maneuvers that I was taught by a mentor is delivery of posterior arm. And there's a lot more literature supporting that as a primary maneuver. So rather than like me rotating baby or getting mom on her hands and knees, if she's epiduralized and she has a dense epidural, then a lot of times if McRoberts doesn't do it, then what I usually do is, so if baby's like this, and this is posterior arm, you can actually sweep in and feel along this part of their arm, grab them by the elbow, they just sweep their arm up and they rotate all the way out. And that puts a lot less, when you're pushing this way, you're not stretching out those nerves. So that decreases the risk of a brachial plexus injury in a lot of deliveries. But that's one of the number one things we think about, as well as any kind of clavicular injury. So fractures here, you can fracture the clavicle even without a shoulder dystocia, but sometimes that is how we get the baby out, as well as sometimes I've seen them along the humerus. Now, these fractures sound really scary, but again, when we think about time wise, babies heal really well. And I don't want to discount the pain and discomfort they go through with those fractures. We treat them for it. But when you think about that fracture is going to heal in 1 to 2 weeks, and that sometimes if that happens, that could be the reason why the baby was able to get out, is if that bone broke and it decreased that surface area, we were able to get baby out. And then usually the pediatricians will explain, and we'll explain that to the parents and everything that goes on. But those are the most common risks that are associated for mom and for baby.
How often are babies with shoulder dystocias needing to be admitted to the NICU for any amount of time, whether it be 4 to 6 hours all the way to a couple of weeks?
I wouldn't say I see a ton needing full NICU admission or observation. I think a good amount of babies do maybe end up needing a little bit of resuscitative support. They come out pretty stunned, not only just from being stuck, but we're manipulating them a lot. And even though I know it's in their best interest to get them out, think of your baby just entering the world and you have some stranger's hands manipulating your shoulders, manipulating your body. And so they come out and they're like, what the heck just happened? Now, if we think about a neonatal resuscitative world, we think of NRP as you're drying and you're stimulating the baby. And depending on what your birth setting is, you may see different practices. Sometimes if it's a shoulder dystocia, you clamp and cut right away. You're taking that baby to the warmer. We know that there's evidence that shows if a baby needs resuscitative help, why are we clamping the cord so early? They need that extra blood and oxygen. So I'm trying to advocate for that more within hospital settings, but you also have to have the equipment set up for that, which is
Okay.
the only reason why it is not a universal recommendation, because not all hospitals have the equipment set up to be able to support intact resuscitation. I really think that's the biggest barrier. And then you may and some babies, I would say most babies I deliver that have a true shoulder dystocia, they maybe get a little bit of like CPAP, so some pressurized oxygen without giving them, think of somebody with sleep apnea. You're just giving them a little bit of extra pressure in their lungs, but they don't necessarily need extra oxygen. And usually they're back on mom within 3 to 10-ish minutes. It doesn't take super long. What it does is decreases how much energy they're utilizing to get those first few breaths. So you're not taking their blood sugar. They're not using accessory muscles to breathe. And so even though the first few minutes seem really chaotic, if we can get baby breathing on their own quickly, then sometimes that's what can avoid the NICU admission. So baby can stay with mom longer. So that's we think of benefits risk ratio as far as taking baby immediately to the warmer. But I've also had I had a shoulder dystocia a few months ago that they were getting ready to take the baby over, and I kind of stimulated the baby myself, and I usually will rub their feet pretty good. That's my go-to. Doesn't take off as much vernix, but it irritates them enough without being as aggressive. Baby started crying, and I was like, hey guys, baby's crying, our color's coming back, our first APGAR is 7, let's keep baby on mom. But that again, that's like provider dependent and baby dependent too. It depends on how they act when they come out.
Sure. Okay, what about previous shoulder dystocias? You're at an increased risk of having it again. So, what do we as consumers need to know? And then, what's going through your mind as a provider if you've got a mom that has already had a previous shoulder dystocia?
Yeah, so I would think when we think about, there's a lot of things we can't control as far as risk factors. The things we can control: excessive weight gain in pregnancy and metabolic health. If we can keep our blood sugar regulated throughout pregnancy, even if you don't have diabetes, there's always a level of insulin resistance within pregnancy.
Okay.
So if we can what happens with diabetes, why that can increase the risk, is it changes, even if your baby's not bigger, it actually changes the morphology of where they put their weight on. So we see babies from diabetic mothers, they have more weight distribution in this part. We always say they're built like a linebacker a little bit.
Okay.
So even if they're not like overall bigger, they could be a 7-pound baby, but it's all here in their upper back and their shoulders. And so just that morphology is a little bit different. So one, the lifestyle things that we can do to help prevent gestational diabetes, type 2 diabetes, those kinds of things, keeping your blood sugar under control, try again, only the controllables within weight gain. Sometimes you're doing all the right things and you gain 65 pounds and there's not a whole lot you can do about it. So you do what you can. Increasing your protein content can help a lot as far as keeping your blood sugar well controlled in pregnancy. And walking, mobility. And I think that's another thing in labor. The more mobile you are, it's going to help your baby navigate your pelvis, doing chiropractic care, doing body work throughout pregnancy, so you don't end up in labor and feeling like you, one, either don't have the endurance or stamina to be moving around, or you are and you're like, my sacrum's tight, my hip flexors are tight, I can't navigate this. How's my baby going to navigate that? I think those are things that we don't always think of directly affecting the risk of a shoulder dystocia, but I see how body work positively impacts people's labors and births. And so why wouldn't it also positively impact someone's ability to navigate a dystocia? And then, like you said, upright birthing positions. And sometimes you can still have a dystocia if somebody's pushing in hands and knees. The difference is, I think, what resolves it is just the movement. So if somebody's in hands and knees, maybe all they need to do is go into their runner's lunge instead of flip-flopping all the way over and doing all of those sorts of things. Anyone who's had a previous shoulder dystocia, the things that I'm thinking of as a provider is having extra people on standby, whether they're in the room or right outside the room. They know when we're pushing, so if they need to respond, they can do so quickly. Sometimes that means an extra nurse or two in the room. I'm having hemorrhage meds available just in case. And then again, I'm probably going to spend a little bit more time talking through the patient so that we can pre-brief. What are we going to do if this happens again? What do I need you to listen to? It's maybe not my quick 5-minute spiel. We're maybe talking through maneuvers a little bit more in depth of, hey, what happened last time? If you don't remember, okay, we're going to start with this and we're going to start with this. And if that doesn't work, or if I feel this on your baby, if you hear me call out for the doctor, this is why. I'm trying to give them as much anticipatory education as possible, again, so we can decrease the amount of trauma that's involved.
Oh my gosh, you guys, now I'm obsessed with her.
Oh,
Literally
I
obsessed with
love
her.
this because we just get to nerd out over all my favorite things, because that I think is where we make the difference in hospital birth, is how do we make the inherently scary things less scary? And then how can we normalize the things that have for generations or for decades been chaotic that didn't actually need to be? So it's just, we're bringing the thermostat down a notch on all of those things.
Yeah, and just reducing that birth trauma. It's birth does not have to be inherently traumatic, and it irks me to no end when I hear people say birth in and of itself is traumatic, and I'm like, but it doesn't have to be. I've literally been to thousands of births that were not traumatic. I have supported so many women over the last 10 years that did not have any trauma. They walked away with literally no trauma. They pop out a baby and they go, when are we going to do this next? I'm ready for the next one. And you're like, what?
Yep.
Were you present for the last 28 hours? I'm ready for a freaking nap. And
Mhm.
that is what birth is. I always hold space for the unavoidable birth trauma, right? That we just can't avoid, we won't be able to prevent, but it
Mhm.
is so small. And
Mhm.
it can be mitigated by the way that you are treated and the way that those situations are handled
Mhm.
in those times, right? And I think for me, that's really my end goal.
Mhm.
Okay, is there anything else that we haven't covered that you feel like women need to know about shoulder dystocia, or as a provider, you're always really sure to tell people about shoulder dystocia that I haven't asked about yet?
I don't think so. I feel like we covered most of it. I think just reiterating the fact that if this is something you experience, do not discount the power in debriefing with your
Yeah.
care team, even if it's not your provider, asking your nurse. Maybe your provider has to run and do another delivery, or they have to get back to the office and you don't want to forget, and your nurse is the one that's helping you breastfeed or get you up to the bathroom. And just a quick, hey, I understand everything that happened, but can you walk me through it a little bit more so I can understand? Because I think in any traumatic situation, whether it's birth or outside of birth, anyone could agree that the more we talk about it so that you understand it is going to decrease that trauma. So I just want to reiterate how important that can be for like a patient's own healing. And then just the importance of knowing your provider, or at least the care team. Even if you are seeing a practice where you don't know who's going to deliver you, understanding, asking them, like, hey, how does your facility normally handle this type of scenario? What support? Maybe this is a stress point for you in your pregnancy. Maybe a shoulder dystocia is like the biggest fear that you have. Ask them, like, hey, do you guys have a NICU? Who responds to a shoulder dystocia? Giving yourself as much information as possible so that you aren't carrying that fear with you. Because I've also seen births stalled out because they were like, hey, right now my baby is safe. And if I keep pushing, and I actually experienced a little bit of that myself with my second birth. I birthed at home with another amazing midwife, and my labor was very long, not how you would typically think as a second time mom. It was very long. And I remember right as we got to the point of me involuntarily pushing, I felt how big my baby's head was. And for 15 seconds, I thought, oh my gosh, what have I done? I'm going to be the person who has a shoulder dystocia at home and my baby's not going to make it. That was the thought that I had in my. And thankfully, physiology took over. And before I even had the chance to mutter that fear out to my midwife, my baby was born into the water. But I also think that my fears, I had a lot of fears about a home birth. And even though I chose that, I was letting go of a lot of inherent beliefs that I had. And I think that part of that is what lengthened my labor. I think my body knew and my brain knew that I had that was my biggest fear was having a shoulder dystocia at home, and not due to my midwives not knowing what to do, but sometimes there's just nothing. The maneuvers don't work and they don't have the resources. And I'm like, if I'm going to be that less than 1% of statistic, and that stall in my labor is what caused my own birth trauma, not my midwives. They were amazing. My birth itself was amazing, but my own fears are what caused that in and of itself. So I think the more that we can let go of those fears and speak it out ahead of time at your prenatal visits, ask them how they would handle it, and I think that gives you so much power as a patient.
Oh my gosh. This has been such a good conversation.
Yeah.
I think it is such a conversation that so many people need, but they're scared to ask. And of course, leave it to me. I'll never be scared to ask the scary things. I really appreciate being able to have providers on that present things in not scary ways. If we don't talk about the scary things, they're going to remain scary. So the best ways that we can do it is to let's talk about the scary things. Let's give you the real information, the hard data, the true numbers, and then we can talk about the things that you can do to avoid it, to prevent it, to resolve it if it happens to you. The scary things are not going to go away, you guys. And so if we don't talk about it, they're just going to remain this really looming cloud over us. You have to confront these things. I promise you it will make you feel better. So, Marisa, honestly, from the bottom of my heart, from the top, the left, the right, all of it from my whole heart, thank you so much for being here. I'm like so truly appreciative. I know that everyone listening has really enjoyed this conversation, and I think you really did a great job of laying out something that seems so scary in a way that makes us feel super, super empowered. If people wanted to get in touch with you, if they wanted to learn from you, if they were in your area, how can people connect with you?
Yeah, so I keep my social media pretty private, but I did actually just create a little midwife education Instagram. So marisadawn.cnm. Hop over there. I do not do this full time by any means, but I also love having these I just love to nerd over all of the things that I'm passionate about. And I have so many friends and family that love to ask me questions. And I figured this is a nice little space to put all of that information. So you can follow me over there, and then hopefully we can chat about some more birthday things. But thank you so much for having me. I feel like I could talk to you for hours about all of the things, but I appreciate it.
I definitely feel like our souls are connected and maybe even like we worked alongside each other in a past or a future
Yeah.
life. And I love that so much. All right, you guys, thanks for being here with us today. I know that we talk about some scary things on this podcast, but it is not to scare you. It is to give you the information so that you can have a confident birth, so you can be informed about true risks that comes along with pregnancy. And while pregnancy in my philosophy is not inherently a risky or bad thing. It doesn't inherently mean that you're sick. There are certainly risks that come along with it, but that's with anything in life. And so I want you to have the education, I want you to have the resources, and I want you to be able to have these conversations that will give you the support so that you can go in and navigate these conversations, navigate these situations with your provider and feel good doing that. Feel like you get to stay in control, because we know that so much of birth trauma comes from you feeling that loss of control. And I think by having these conversations and empowering you with this information, you will be able to remain in control even when something scary or unexpected happens in your birth. So, thanks so much for being here, you guys. I'll see you in the next episode. Be sure to follow Marisa on social media. And you can find me at Tranquility by HeHe or at the.birth.lounge. Until next time, head to your app store and download the Birth Lounge app for evidence-based childbirth education and data-driven postpartum support delivered straight to your phone. Bye. Thank you so much for tuning in today. I love hanging out with you, and it is an honor to be your go-to gal when it comes to preparing for your baby. If you've enjoyed today's episode, please leave a 5-star review and tell others why they should be listening to the Birth Lounge podcast too. You deserve to have a birth that you love with a provider that values your autonomy and respects informed consent without all the trauma that you so commonly hear about on social media. New episodes air every Wednesday and Friday. Hit that follow button so you never miss an episode. I'm HeHe, and this is the Birth Lounge Podcast.